I'm Dr. Cecil Bennett. There is no doubt because of the opioid epidemic, as providers, we have to be very careful and deliberate in the manner we manage our pain patients and patients taking addictive medications, such as benzodiazepines like Xanax, muscle relaxants like Flexeril, and ADD meds. Many providers have stopped seeing pain patients altogether for fear of doing something wrong and getting into trouble. Some providers prescribe pain medications but do not have a structured program for management to assure compliance and safety. There are steps providers can take to manage their patients that are prescribed medications that may be addictive. Before we review those steps, it is important to remember something. We need to remember that diseases like chronic pain, fibromyalgia, anxiety, and ADD are real. They're not disorders patients just can snap out of. Pain is unique and individualized. Lumbar back pain from degenerative disc disease may be rated 5 out of 10 for one person and 8 out of 10 for another. A person's perception of their pain is not wrong. While we clearly have concerns for the overtreatment of pain, there should be also some concern for the undertreatment of pain. Undertreatment of pain by providers may cause some patients to seek relief from more nefarious sources. It is important to remember there is a difference between dependence and addiction. Dependence refers to the physical dependence on a drug where tolerance or withdrawal may develop. A patient may feel terrible if they miss a dose of their medication. Addiction refers to a change in the behavior where patients abuse their medications and may take more of their prescribed dose because of intense cravings or for the purpose of getting high. The percentage of patients prescribed opioids that actually go on to abuse is not as high as you may think. According to Rivermend Health, experts in addiction, about 15% of patients prescribed opioids will go on to abuse them. Regardless of the low percentage of patients that may go on to abuse pain medications, every precaution must be taken to assure compliance and safety. So what steps can be taken? We need a complete and thorough addictive medication assessment. This can be done for new patients that come to see you for their management or patients you currently treat but have never really gotten a thorough addictive medication history. During this visit, it is important to document: is there objective evidence for the use of their pain, anxiolytic, or ADD medications? Documentation such as reports from a pain management clinic, neurologist, psychiatrist, or orthopedic clinic? Are there prior prescriptions for the addictive medications? We should get a thorough account by the patient of the history of the disorder in question. Are there radiographic reports such as X-rays, CTs, MRIs, etc. to support the patient's account for their injury? If no objective study or referral was done in the past, depending on the disorder in question, I would suggest you get one. Do not be an island. Get some support for your treatment. Some of us were told in residency that if a patient says they can take this pain medicine and not that pain medicine, they are drug seekers. That may not necessarily be the case. We should try to always use sound, experienced clinical judgment and not always assume the worst when collecting a history from our patients. You should also have your patients sign a pain or drug of abuse contract. This contract allows the rules under which addictive medications may be prescribed or discontinued if the agreement is violated. You should be able to find samples of this type of agreement online. Modify them to suit your clinic. You should also have a pain management regimen. Your regimen may include physical therapy, lifestyle modifications such as diet, exercise, weight loss. As far as medication treatment options are concerned, you should consider acetaminophen, NSAIDs, antidepressants such as Cymbalta or tricyclics, transdermal patches, anti-epileptics such as Neurontin, muscle relaxants, codeine, milder opioids, or stronger opioids. Develop your own regimen and remember all patients are different. The starting point on the regimen or the order of the regimen may change depending on the patient. The important thing to remember is that you determine your level of comfort. Determine how far you're willing to go before referral. I would recommend getting a baseline pharmacogenetic or PGX testing if covered by the patient's insurance to determine if a patient is a slow or rapid metabolizer of a particular class of medication. Depending on their genetics, one patient who may be a rapid metabolizer may need a higher dose of an opioid than another patient. A PGX screen will confirm this. This PGX knowledge will help greatly to determine what medication to use to treat patients not only who have pain, but have anxiety, ADD, depression, and other mental health disorders. Perform a urine drug test on the first office visit and routine drug screens in the future to assure compliance for patients taking pain medicines, muscle relaxants, anxiolytics, or ADD medications. This urine drug screen can be done via a simple cup-based urine screen in your office, which is not the most accurate way of doing a screen. Or you can send the specimen off to be tested for compliance by a confirmation process that has 95% plus accuracy. You may choose to do both. I hope this video on addictive medication management was helpful. Please remember that the information presented are just suggestions. You may choose to do your own research to determine your management of patients taking addictive medications. Following is my contact information. I welcome the opportunity to speak with you and helping you to develop an implementation plan for addictive medication management in your office. Feel free to send me an email or give me a call. Thank you.